Today, I'll be talking about practical approach to edema to understand the framework for characterizing the etiologies of edema. Then I'm going to focus on very basic knowledge, not advanced knowledge. And I hope this lecture will be beneficial, especially for med students or healthcare professionals. Right. So these are things I'm going to talk about today. I'll start with case presentation. I'll talk a little bit about differential diagnosis and mechanism of edema, and history taking, physical exam, and finally exams to order. Okay, so I'd like to start with this case. 54-year-old woman visit the hospital because of worsening leg swelling and shortness of breath. The swelling began a month ago and has steadily increased since that time. And what would you like to do with this case? In a clinic or emergency department, we often see this kind of patients. In order to ask good questions, or in order to take a good history of the patients, we need to know the differential diagnosis of edema. So the first question is, which of the following organ disorders is less likely to cause edema? Heart, kidney, liver, lung. And you have already answered these questions, and most of you have answered correctly, which is lung. There are three major causes of edema, which is heart failure, renal failure, and liver cirrhosis. So when you see a patient with edema, first of all, you can think of dysfunction of three organs: heart, kidney, and liver. And this is very basic, but also useful approach to assess a patient. Okay. Then other differential diagnoses of edema include low albumin level, which means nephrotic syndrome, malnutrition, which is quite common, protein losing enteropathy. Other differentials include cellitis, drugs, lymphedema, and hypothyroidism. Then mechanism of edema. Mechanism of edema can be divided into four categories: increased hydrostatic pressure, decreased oncotic pressure, increased capillary permeability, and lymphatic obstruction. Okay, I'm going to explain all of them. Then the first category is increased hydrostatic pressure. This is the most diverse and contains three distinct subcategories. The first one is intravascular volume expansion. So pressure is higher because there is more fluid squeezed into the extravascular space. We see this in kidney failure patients, in pregnancy, and medication side effects. The next subcategory is venous obstruction and venous insufficiency. And in these etiologies, there is some physiologic or anatomic problem that is preventing blood from moving back to the left side of the heart. Causes of these conditions include heart failure, pulmonary hypertension, cirrhosis, which is related to portal hypertension, and deep vein thrombosis, and a condition called chronic venous stasis, in which normally, if it's a primary abnormality, is dysfunction of valves in the veins that normally have venous blood moving from a distal to proximal direction. Also, in terms of heart failure, it's worth noting that many affected patients will also have an intravascular volume expansion. So combination of these conditions. The last subcategory is arterial vasodilation. In this situation, there is a reduction in the pressure drop between arteries and the capillaries. So even though arterial blood pressure decreases, capillary hydrostatic pressure might increase. This is a mechanism behind the peripheral edema that can occur in patients on antihypertensive medication. The next one, decreased oncotic pressure, which means hypoalbuminemia. This category has three notable conditions. First, malnutrition due to decreased protein intake, which is very common. And second, cirrhosis due to decreased protein synthesis. And third, nephrotic syndrome due to protein loss in the urine. Okay, then the third category is increased capillary permeability, and common causes are sepsis and cellitis. And the last one, fourth category is edema due to lymphatic obstruction. This condition presents differently and is treated differently, so it is given the special name lymphedema. Lymphedema is predominantly caused by malignancy, either from surgical lymph node dissection or from extrinsic completion of lymphatics by a tumor mass. In summary, there are mainly four categories of mechanism of edema, and increased hydrostatic pressure and decreased oncotic pressure are common. So let's move on to history taking. When assessing a patient with edema, we have a lot of questions to ask, but key questions to ask in the history include the duration of edema, like when it started, or it is getting gradually getting worse or better. And its distribution, that is whether it's in the legs, arms, or generalized. If the edema is bilateral, it is important to know if it's symmetric or asymmetric. Ask about the presence of pain or redness of affected extremities, and also ask about abdominal distension that might indicate the presence of ascites with liver function disorder. A history of cardiac, pulmonary, liver, and renal disease, including risk factors for each, is obviously very important. And finally, take a good medication history, and we should include over-the-counter meds. Then the question number 2 is, which of the following medication is most likely to cause edema? Angiotensin 2 receptor blocker, calcium channel blocker, beta blocker, and hydrochlorothiazide. All of them are common antihypertensive medication, and you have already answered this question too. And most of you answered correctly, but calcium channel blocker can cause this. There are actually several medications that can cause edema, and calcium channel blocker is one of the most common causes. NSAIDs such as ibuprofen, corticosteroids like prednisolone, hormones and related compounds also induce edema. So we need to pay attention to what medications patients are taking. Okay, so let's move on to the physical exam. Always take the vital signs at first. And a focused physical exam should include a characterization of the edema. The remainder of the exam should include cardiac, pulmonary, and abdominal exams, as well as a general skin exam. looking for things such as evidence of chronic venous stasis in the legs and the signs of liver disease anywhere, such as spider angiomas. In terms of characterization of edema, the distribution, symmetry, extent, and severity are especially important. Also look for erythema, warmth, and tenderness, which might suggest a cellitis or a DVT. In addition, you need to assess whether the edema is pitting or non-pitting, and whether the edema is slow or fast. Which of the following is the cause of non-pitting edema? This will be the last question. The cause of non-pitting edema: hyperalbuminemia, heart failure, hypothyroidism, and DVT. What do you think is the cause of non-pitting edema? And the answer is hypothyroidism. In order to assess the pitting edema, you should check whether the pit remains in the skin after you release following a few seconds of pressure with your finger. Basically, we use our thumb. And as a general rule, lymphedema and hypothyroidism predominantly cause non-pitting edema, while every other condition I have mentioned before causes pitting edema. If you see a patient with pitting edema, you also need to check the pit recovery time, which means how many seconds it took for the pit to return to normal. In general, pit recovery time of less than 40 seconds is defined as fast edema, and this condition suggests decreased oncotic pressure, such as hypoalbuminemia. On the other hand, pit recovery time of 40 seconds or longer means slow edema, which is mainly due to increased hydrostatic pressure, which means heart failure. Okay, this is a really important part. And based on the physical exam findings, we can have practical approach to edema. Here's a summary. Among patients with generalized edema, differential diagnosis of fast pitting edema include liver cirrhosis and low albumin level. And slow edema can be due to heart failure. And the most common cause of non-pitting edema is hypothyroidism. And differential diagnosis of localized edema include DVT, cellitis, lymphoedema, or a malignancy. Okay, so let's move on to the last part, exams to order. We have to order some tests based on our differential diagnosis or findings we have obtained from physical exam and history. But key exams to order for working up edema include blood tests such as CBC, basic metabolic panel, liver function tests, albumin, thyroid function, BNP, and urinalysis looking for proteinuria. Additional tests to consider depending on preceding findings include EKG, chest X-ray, and echocardiography. Okay, now this is a takeaways of this lecture. So let me summarize. Edema is caused by 4 different types of mechanisms. 3 main factors causing edema are heart, kidney, and liver disease. Okay, and take a relevant history, physical exam, and oral exams to confirm the diagnosis. Right, so this is the end of the lecture. Now I'll be answering if you have any questions.